was probably classified as being overweight when the restrictions started. So there were a couple of people who noticed that I was losing weight, but the majority of the feedback was, "You look great. Like, what have you been doing?" And I was going to the gym a lot, and people were like, "Oh, it's so great that you're getting healthy and getting fit. Like, good on you. I wish I could do that." There was lots of that kind of feedback.
It takes 7 to 10 years on average for someone to seek help for an eating disorder. Shame, stigma, ambivalence, and lack of awareness can all contribute to the delay. Early intervention within the first 2 years improves recovery rates and reduces the risk of physical consequences.
Well, eating disorders are mental health problems as well as physical problems, so they can present in either or both ways. The main physical problems that people present with, or physical changes, are changes in the way that they eat and changes in their body size. So a parent, for example, may notice that their child no longer wants to eat the evening meal with them or disappears off into their bedroom, or if they're having problems with binge eating, there may be lots of food wrappers that suddenly appear, or food that starts to disappear from the fridge, for example. In terms of body size, there may be unexplained changes, either fluctuations in the person's body size or severe reductions in weight or increases in weight that are happening quite quickly over time. They can also present to another physical ways, such as with vomiting. There may be problems with dehydration, with physical health problems, with low potassium, things that the GP or the dentist might pick up on, with dental caries, for example, due to vomiting. The mental health problems, though, are equally as important, and really the development of anxiety or depression in a young person or a middle-aged person who may be seeming to have other difficulties with food or eating. It's important to ask fully about eating disorder symptoms, because they can definitely present with problems related to anxiety and fear around food and eating, and also depression.
I think just the change in behaviour, the change in mindset. In my experience, I lost, I guess, quite a significant amount of weight at a young age, at around 17. So, I went from developing these healthy habits to then changing that to just what I thought was right. And I think that's just due to that lack of education around eating disorders. But yeah, so just noticing that mindset change and yeah, definitely the physical behaviours.
Yeah, so warning signs is a really important area in our area, because it's kind of unusual for an individual, particularly a young person, but for an individual in general, to just volunteer to you, "Oh, look, I'm having problems with my eating." And this may be largely to do with shame and guilt that's associated with those problems, but it's not easy. So it means that for us as professionals that we kind of need to know what we're looking for. But because it's hard, and as I said, people often don't directly volunteer, or they might even deny some of that, we need to look at signs. Their medical signs, physical signs, their behavioural signs, and their psychological signs. And we need to keep alert to the three areas. Because one of the things I think can happen is that if we look at only one set of signs, we can sometimes miss what's going on.
Physical or medical warning signs include restriction of energy intake, weight loss, weight gain, or fluctuations in weight, gastrointestinal problems, injuries from over-exercise, infertility issues, feeling cold despite the weather, fatigue, calluses on knuckles, damage to teeth, swelling of jaw and bad breath, which are all signs of frequent vomiting, fainting or dizziness, and chest pains or heart palpitations. Psychological warning signs include preoccupation with eating, food, body, shape and weight, feeling out of control around food, distorted body image, black and white thinking, using food for emotional regulation, and changes in emotional state. Behavioural warning signs include restriction of energy intake, dieting or binge eating, frequent trips to the bathroom during or shortly after meals, vomiting, using laxatives or using other compensatory behaviours, changes in clothing style, compulsive or excessive exercising, obsessive rituals around food preparation or eating, sensitivity to comments about body, eating or exercise habits, and secretive behaviour around food.
I had a friend when I was at uni who noticed pretty quickly that I changed quite a lot in terms of how I was eating and how I looked. But I had one friend in particular who I spent time with. We would go for coffee, and he kind of noticed that what started as coffee and something turned into coffee, which turned into black coffee. He was like, what's going on? And I trusted him. I spoke to him. He asked me to make an appointment with my GP, which I did.
Watching and waiting may result in the person not getting as prompt a treatment as they were. They may be ready at that time to actually be accepting treatment. They may be looking for some opportunities to go into treatment. So you may miss an important opportunity to help that person turn the eating disorder around and avoid living with the eating disorder for years, as I said, which is often the case for many people. They have the eating disorder for many years before getting help and turning it around.
I always think back to when I was in the depths of my eating disorder, and I wish that I had have sought help sooner. And yeah, I feel like, you know, I probably went for about 5 years without getting the help that I needed. And I just think of all of the health issues that I suffered in that time that could have been prevented if I had have sought treatment sooner. And if I had have been educated more on eating disorders, or if my GP had have been more educated around eating disorders, then I think I would have been able to seek help sooner. But I didn't know, and my GP didn't seem to know. So yeah, it took years and years.
So really talking about what's at stake when we're faced with a person and we're asking ourselves the very good question to have in our mind, could this be an eating disorder? What's at stake? And what is really at stake is this is a juncture for that person where they can go in one of two directions, and one direction leads to early intervention into their eating disorder. And if we know anything in the eating disorder field, is that earlier intervention leads to better outcomes. The other juncture, unfortunately, can lead to years and years of continuing with the eating disorder, sort of embedding it further into the person's life, and that can lead to chronic illness or death, and chronic psychiatric illness. So a really, really impeded life, or death through medical complications of the eating disorder or suicide. So when we're faced with that person, it's sort of a really good question. Could it be an eating disorder? There's a lot at stake for this person when I kind of make that judgment. So always really good to err on the side of let's find out, let's find out.
So I think, having clinicians ask the questions and then responding in a personal way makes such a difference to people responding in a kind of non-compassionate. It's like, I don't understand, I don't know what to do, so I'm just going to assume that she's fine.
I spent a lot of my life in doing research showing that there are effective treatments, and also, however, working with people in the community, understanding that the majority of people in the community are not accessing those effective treatments. And closing that gap is a significant challenge, and one I think we have to overcome. We have to overcome it through a better community and understanding, and what we call health literacy around eating disorders in the community, so that people who are of a larger body size can understand that they too can have bulimia nervosa. Or indeed they can have forms of anorexia nervosa, as I said earlier, if they've lost a large amount of weight. But also educating healthcare professionals to recognise that as well, so we can empower people to go and present to their GPs, but it's not very helpful if then the GP says, but you can't have an eating disorder, you're not thin enough. So also educating healthcare professionals to understand that eating disorders occur in men, they occur in women, they occur in people of gender diversities, they also occur in old people and young people. You're not too old to have an eating disorder, you're not too young to have an eating disorder, and you're not too poor or you're not too rich to have an eating disorder. They occur across the entire socioeconomic spectrum, and they occur in people of Aboriginal and Torres Strait Islander origin as much as the other Australians that we have as well.
I think another couple of particular situations that are really useful in asking that question, could this be an eating disorder, that can sometimes get in the way of us having a clear look at it, is sometimes if the person's living in a bigger body and we get preoccupied with the fact that health and weight loss, that paradigm clouds our capacity to look at, does the person actually have an eating disorder? So separating that in our mind is really, really important, because the shape of your body isn't an eating disorder. Living in a bigger body isn't an eating disorder. It's the pattern of eating and the way that echoes into your mental health that is the eating disorder. So just separating that out.
I approached her with, I'm having a hard time controlling my eating. I don't really know what's going on. I've gained a lot of weight. And instead of her sort of compiling that and thinking that I may have an eating disorder, she sort of looked at the weight gain and just wanted to treat that as its own issue, as a standalone issue. I guess my eating habits were probably not seen as that serious, I guess. I don't know.
And the other one that's important to think about is that we're getting a lot more cases of what we call atypical anorexia nervosa. So, and what that involves is that the person has all the signs and symptoms of anorexia nervosa, which we know is a very serious psychiatric and medical crisis in a person's life, but they look a normal weight. And that's because their weight loss started when they were bigger. So when they come to us, they can look a normal weight, and there's a bit of a danger of saying, oh, the person looks okay. I can't see any really big problem. But actually they can be as medically compromised and as in much danger as somebody who's at a very, very low BMI and looks obviously very ill and needs to go to the emergency department. So keeping in your mind again the idea that we can't tell from the outside if a person has an eating disorder. So we really do need to do the kind of going in, finding out across those sets of signs.
I think, from a health professional's perspective, if you've got someone coming to you and they're talking about, because obviously something common is losing weight. A lot of people say, oh, I want to lose 5 kilos and whatever. I think asking them what that looks like for them, how are they actually doing that, not just being like, oh yeah, that's great, good luck to you, because obviously we associate weight loss with success, so which isn't always the case. So I think just asking questions and being like, how are you actually doing this? And have you noticed any, behavior changes in yourself, or, are you eating? Just little questions, just, brush it under the rug. In saying that not everyone is going to develop an eating disorder or has one, but, I think it's too risky to take that chance to assume, that they're fine, they're just trying to make a lifestyle change.
I don't know, I kind of wanted to hear, I don't care what you look like, I can see that you're not well, and you can get better.
There's a kind of firm and kind stance in this situation. You're not trying to kind of argue the person out of their behaviours at all. You're curious and interested. You're really non-judgmental, and that will feel different to people because they've been experiencing, probably if they've talked about food and eating, or if people around them are worried, they get the feeling everyone's judging them, everyone's saying there's something wrong with you. So it's really helpful if you can use the stance when you're talking to people, which is interested and curious and non-judgmental, just more in the mode of, yeah, I get that. And when that happens, does that sort of thing happen? Yeah, okay, I understand. Not in any way kind of really at this point trying to change anything, but being quite firm about the steps that need to be taken next. So we have firm on one hand and kind on the other, and I've just tried to show you kind, and firm is more along the lines of, okay, so what I'm understanding is that there could be problems in this area. So what we're going to need to do is I'm going to refer you to this person. We're going to take those steps.
Sometimes there can be a sense of we must do something now, we must get this person right to hospital right now, and that can be very stressful for the person, and then they can just run away and avoid because they have that sense, oh, are you going to detain me? So just being very careful, very judicious about the words that you use or the way that you approach it for the person, and saying, look, what would you like to do? What can I do to help you do something about this now? How can we make some first steps? For example, ring the ED helpline of the Butterfly Foundation, or go and see your GP and I'll go with you. I'll be with you there in the waiting room. I won't go with you to the GP, but I'll be with you in the waiting room supporting you in taking that important first step.
Yeah, okay, well let's separate screening from assessment. So screening is more when we're using a small number of questions to help us ascertain whether or not there is a strong eating disorder risk. And then assessment is when we're actually saying, now I'm sitting down with you and I'm going to go carefully through all the signs and symptoms and see what that might be.
Well, we have a number of what we call self-report questionnaires, which people can just fill out themselves online or on pencil and paper. One that's very commonly used in primary care practice is called the SCOFF, just a simple 5-item questionnaire, which if someone scores at least 1 or 2 on that, probably indicates they are likely to have an eating disorder. And that can be the start of the conversation for the person about their eating disorder. Another one is called the Eating Disorder Questionnaire. There's a 12-item version again. It's available online. It's been published in an open access medical journal called PLOS ONE that you can just Google and search quite easily. Again, that's just a simple 12-item questionnaire that a person fills out, and really if they answered yes to 1 or more of those questions, that indicates probably to ask a follow-up question and to interview the person. But the only way to really move forward for the person is to talk with them. Eating disorders are a mental health problem, and we assess and treat and manage mental health problems by talking with people.
I'd seen and heard the word bulimia, thrown around just wherever in life, but I didn't know that that's what it meant. And then I guess that realization of self-diagnosing myself and being like, yeah, wow, this is what it is, was then, I guess, really scary for me.
Assessment is a somewhat more formal process where we're trying to move from the possibility of a risk. We've established there's a possibility of a risk, and our assessment is exploring more deeply with that person what the signs and symptoms are, with an aim ultimately of matching them up to a possible diagnosis and understand what's going on. So some of that is obviously just asking the person about what's going on for them, but there are some assessment pro formas. So there's one called EAT26, which is very much focused on people's eating behaviours. And there's something called SET, which is a compulsive exercise test, which is really useful because exercise is becoming more and more a presentation in eating disorders for everybody, but even more specifically for male eating disorders, which are on the increase. So that's useful. The one that's the sort of gold standard that's used in research and I find to be really useful, I use it the most as a clinician myself, is called the Eating Disorder Examination Questionnaire, or EDEQ. And what it is just 4 pages of questions and the person fills it in, or if you want to, you can ask it verbally. And it just gives you a really nice comprehensive go through the different kind of eating behaviours. And I've found that for some clients it actually is easier to write it down than it is to speak verbally initially. And surprisingly, people can be very honest and direct sometimes when they fill in the EDEQ pre-session or after the session or with you in session in a way that they might find difficult without the cues being there. So, because if you're asking somebody questions, say, around vomiting is inherently kind of shameful. So having it as part of a questionnaire or something written sometimes can take some of the sting out of the personalness of that.
Well, I would usually start by telling the person what I know already, that maybe they've come with a questionnaire filled out. So you might start by saying there were things on this which indicated that you might have an issue of an eating disorder, and then just asking the person to tell you about their eating disorder. When did it start? What did they think were the triggers? What were the important things that happened on that journey through the eating disorder that may have helped the eating disorder or may have further entrenched the eating disorder for them?
I didn't actually seek help, I guess, the ideal way. It took for me to get to a point where I felt like taking my life was the only option I had left.
One of the tricky things when you're first talking with somebody about the possibility that there may be an eating disorder, I guess you're deciding how urgent is this referral, and that's going to be a really important question in how you then proceed towards medical and psychiatric or mental health help. It's really helpful if you can actually explore a little bit with the person around, are they safe? And there are 2 parts to that safety. One part of that safety is, are they psychiatrically safe in the sense of, do they have impulses to self-harm or to suicide? Unfortunately, that the rate of suicide in people with eating disorders is much, much higher than that of the general population. It's even much higher than people with depression, major depression, which is normally the diagnosis that we'd associate with higher suicide rates. So suicide is always there as a possibility, and then so is difficulty with their medical signs and their heart. So just at this early stage when we're first talking to them, it's probably really useful if you can talk to them gently around, do you feel safe in yourself? Even asking a question like, have you had any thoughts at all about hurting yourself or killing yourself, so that you know and so that you can pass that information on, and so that informs you about how urgent it might be to, in that case, get that person to psychiatric help. And then the other side of it would be the medical risk, saying to the person, do you ever feel really dizzy? Have you fainted lately? Are there any signs that you're not sure that you're actually physically well? Because sometimes people might tell you something like, oh, actually, I wake up in the night with really thumping heart. And they haven't told anyone else that, because in the state they're in, they've minimised that. They tell it to you and you think, oh gosh, that's really dangerous. I actually need to really expedite that medical check. So it's just a way of getting a first sense of the safety of that person. That's very useful.
At that point, that's when I guess, it was, I'm going to get the help. All my family and close friends now knows what's going on and what I've been struggling with. So it was really relieving, not, knowing that, I'm going to get help now.
Another really important part of it, particularly if it's a young person, is to draw in the family. So people who are experiencing an eating disorder, especially early on, might have an impulse to secrecy, because as I mentioned, there's a lot of shame and difficulty around that, and also the desire to kind of sometimes hold on to those behaviours. Part of healing and part of getting better is really being supported by your family and the people around you. So encouraging that person to talk to their family, bringing the family in if it's at all possible, and starting to get that circle of support that's actually going to be crucial to helping them discern what's going on for them. And if it is an eating disorder, then that's going to be really helpful in terms of recovery. Sometimes people are okay. They'll be like, yep, we can bring in my husband, we can bring in my mum, we can talk to. Sometimes people are really, really rule-based around it. They try actually actively to put up sort of blocks, even to the medical person talking to the mental health person, or they might try and have a lot of professionals involved but not allow them to communicate. If you do that, if you have a treatment team that isn't communicating, it's pretty much a recipe for failure. You absolutely have to have people on the same page. So gently, we want to ask the person, we want to involve them, why it's important. But again, it's another one of those things about being firm and kind. So in any treatment, when you are trying to get better from any condition, there are kind of things that are really important, and one of them here is to allow people to know about it and to move in. So we just have to be respectful and I guess patient but firm, that we really need to bring people in.
Well, the next steps, once you have identified and you discuss with the person that they have an eating disorder, is to think about where to go for treatment. We have a lot of treatments that are very effective for people with eating disorders, and the vast majority of people with eating disorders can be treated in the community with a community psychologist and with their general practitioner, and perhaps with a dietitian as well, as part of the multidisciplinary team. So that's the usual path, would be to make a referral to someone who's working in the community setting and what we call the outpatient setting. But some people with more severe eating disorders will definitely need help with more what we call intensive treatment settings, for example, a day program or an inpatient program. And the core of those programs are just much more support around food and eating, where you're eating with a therapist and with other people as part of the group program, and developing as I say, overcoming those fears and anxieties about food and eating, and developing a positive relationship with food in a group therapeutic environment. There will also be other groups that are involved there. For example, some day programs, the one at Wesley Hospital uses art therapy and equine therapy, so other things that can be brought in to supplement and add to the core psychological therapy for the eating disorder.
Even when I did actively want help, I still had to do a lot of the sourcing of that help myself, and finding specific names of psychologists and hospitals and eating disorder programs, and asking directly for specific referrals. So I guess it's hard if you don't know where to even begin to look. You're not going to find the name of a psychologist that you want your doctor to refer you to. Yeah, it's hard.
The tricky part of this is making sure that the mental health professional that you get involved does have a knowledge of the particular evidence-based treatments for eating disorders, because not all psychologists do, not all social workers do, you know. So there are a few ways to help you. You can look on websites and things like that. You can actually ask the professional really directly, you know, do you work with eating disorders? And if they do, say, oh, so what sort of an evidence-based treatment would you be using?
The person who's holding someone with an eating disorder in the community before they're accessing more secondary level eating disorder informed care, there's a lot of resources that are available online. So sourcing what's online is important. We know that self-help is effective for many people with binge eating disorder and also bulimia nervosa. And there's a number of very good self-help publications, such as a book called Overcoming Bulimia Nervosa and Binge Eating by Peter Cooper, which is often available through public libraries. Not least, people shouldn't have to wait over long to get into treatment. And sometimes that person who's with the person with the eating disorder can help advocate for them to find out, could there be somewhere else they could be seen? They don't have to sit and wait for that particular psychologist. Maybe there's another one that they could see more quickly or in the interim.
We want smooth pathways to service in this situation. We want people to be able to feel supported, that they go step 1, step 2, and now I'm receiving the treatment that I need to receive. And that's not always going to happen, particularly in rural areas or in areas where it's tricky to locate the people. You have to keep trying, you know, you really do need to keep trying. You can't let that fall. On the other hand, if you have actually found the place and it's a waiting list, how do you kind of support that person in the meantime? And I guess the answer to that in part is keep the door open, keep involved. In the interim, you're going to maintain your kind of firm but kind stance. You're not going to try and be changing the person, but you're going to try and stay in touch with where they're at. I'd just really like to invite people into this work and see it as part of their work, so that eating disorder work isn't some sort of thing that happens up in some specialist separate thing in the sky. We do need that expertise. We need that kind of nuanced, evidence-based, skilled capacity is crucial. But just remembering that it's early intervention that actually gives us our best outcomes. So we absolutely need the primary healthcare force and people in the community in places like ballet schools and gyms and things like that to know these signs and to be saying, I can do that. I can answer the question, could this be an eating disorder, myself at the level I'm at, and then I know what to do in order to move that into a kind of skilled treatment kind of space if that's what's needed, but that it is part of my responsibility as someone in the workplace to do that, and that I can, it's fine, I can get this. It's not some separate thing. So it's just inviting you in, please.